With all the political talking points we've heard since the Dayton and El Paso shootings, one thing's clear: these two sides are not likely to agree anytime soon.
Mental illness and hatred pulls the trigger, not the gun.
This president wants to talk about mental health. He wants to talk about video games, other things. Doesn't want to talk about the fact that we need common sense gun safety legislation.
So is it time to put the politics aside and focus on a public health approach to stopping gun violence? That's the goal of my next guest, Dr. Chana Sacks and Dr. Peter Masiakos. Did I get that right?
You got it right.
Close enough, thank you. Are the founders of the Center for Gun Violence Prevention at Mass General Hospital. They join me now. Advancing a public health solution. What is a public health solution to the gun epidemic?
You know, it really means following the data where they lead us. It means investigating this from all standpoints and really coordinating a multidisciplinary approach to figuring out what's going to work here and following the evidence that we know exists and implementing solutions.
Is there a model for this, maybe not in the gun world, but that people could relate to, where there's been a public health approach to some sort of public epidemic, and that's been the road to salvation?
Absolutely. I think there have been so many public health successes. I think that's why we've lowered car fatalities by almost 50%. That's why smoking rates decreased over the last several decades. There are a lot of models here of how you look at evidence and how you follow it where it leads.
You know, but we're almost in an evidence-free society. We know the expression alternative facts, all those kinds of things. There are no facts anymore. So let's assume you both and your colleagues are successful, and you're able to produce new data that makes an even more compelling case than I think already exists. How do you get from data to conversion on the part of skeptics?
I think you do it in any way that we do any kind of scientific research. You find the answers to the questions and you talk about them. I think, you know, let me go back a little bit to the idea of what is public health. Mm-hmm. And for me, public health is in the operating room. For me, it's identification of the injuries that we're seeing now and saying, hey, wait a minute, there's something wrong here. The weaponry that's available now is causing injuries that I've never seen before. My colleagues and I are taking care of these injuries like we are taking care of battlefield injuries. So the observation of what we see in the clinic translated then to what Chana's talking about with respect to data and drive that drive that discussion to the public. I think people will recognize that there's an issue.
You know, the American College of Physicians, I know you know this quite well, urged doctors not that long ago to get involved in this, speak to their patients, that sort of thing. I know the NRA did that stay in your lane garbage and that sort of thing. Did that convince some of your colleagues who were reticent, maybe in reaction to the NRA saying, we know your business better than you do, that they should speak up?
I mean, sure. I think the idea of being told this isn't our lane, of people who do this every single minute of their day, that this is what they do, being told that this isn't their space, of course that galvanized people. But I think what we see our role is saying, yes, this is our lane, but what are the next 10 words? What does it really look like to bring violence intervention efforts into clinical practice and into clinical care?
Well, tell me what it is. What does that mean?
A few things. One is really arming frontline clinicians, empowering frontline clinicians who take care of patients and see people who are potentially at risk, and helping them understand how to interact with patients, how to, in a culturally competent way, talk about firearm safety, to talk about guns. Something, even though 40,000 people a year are dying from gun violence in the U.S., not one thing is taught through most medical training curriculum about how to have this conversation.
How is that possible? How is that possible?
We're here to fix the problem. So I mean, I think that's the piece that you know, sometimes we do better with other types of problems, but you know, we're trying to make a loud statement with real evidence behind it that things are going to change.
Can we stay on the how is that possible lane, sure, for lack of better expression? Yeah. Art Kaplan is a medical ethicist at NYU's on our radio show every Wednesday, and we occasionally talk about the role of doctors doing what you're trying to do. I don't mean in a big way, but I mean in a patient-to-patient way. Identify for me the doctor, even if he or she is a wild Second Amendment supporter, who thinks it's not important to have the discussion that Chana is talking about having with your patient. What's the possible rationale for that?
I'm not sure that there exists such a person.
Are you serious?
I'm serious. I think there are people out there that say that we shouldn't talk about this and it's not our domain to discuss these things with our patients, but in reality, the idea of a trauma surgeon, and I'll use the anecdote of trauma surgery, the idea of a trauma surgeon not talking about this domain when in fact we're talking about putting ourselves out of business is ludicrous. And I think if you go back 5 years in any medical conference when we were sitting around talking about whether we would talk about guns, and the politicization of it has been supplanted by the fact that we're talking about it now. And there's no way that somebody who's doing this for a living, who sees this every day, who talks to parents about the death of their children, can say with a straight face that we're not going to change things.
Can we talk, you obviously have deep professional commitment to this, but I know you have personal connection too. What's the quiet room? I read a piece you wrote about the quiet room. What is it?
I wrote it about a year ago now with a resident that I was training. And it was at the time that the stay in your lane business was going on. And it was the idea, it was an allegory really of what we experience, the worst part of our jobs. It's the idea of walking out of a trauma room, trying to resuscitate a child or a teenager or an adolescent or an adult, and having to talk to the family in a room that's quite banal about the death of a child, right? You're talking to a mother about the fact that you couldn't save their kid. Now, how could anyone not be affected by that, you ask? I think that you can't.
And you have a pretty intimate connection to this too, Chana. Tell us about that. Your family.
Yeah, I mean, 2012 already is my cousin Mark. His 7-year-old son Daniel was killed in Sandy Hook when I was a junior resident, and you know, that was certainly going to Newtown, and there's a picture of him, several. Going back to Newtown and being there was certainly the worst pain I had ever witnessed and seen, and you know, I think a few things come out of that is one is just living with that pain and the reality. You know, I had been a medical student at the University of Chicago, and you can't live and work on the South Side without getting this issue in some sense. But when it becomes a haunting personal reality, it becomes something different.
You know, when you were here with Adam Riley a month or so ago, both of you, you said something that stayed with me. You said something like, I'm not anti-gun, or we're not anti-gun, we're anti-bullet hole.
That's it.
Why are you not anti-gun? For political reasons?
No, I think it's a really interesting question. I think, first of all, I frame it that way. If we're not anti-gun, we're anti-bullet hole in our patients, meaning that is my end game. My end game is not to disarm for the sake of disarming. My end game is to make our patients and our community safer. And whatever pathway the data suggests will get us there, I'm all in.
And let me add to that. You know, there's no reason for anybody to have a 100-round barrel clip.
Like in Dayton.
And like in Dayton, that killed 9 people in 23 seconds. There's no reason that somebody should be able to walk into a school in Connecticut and kill 21 kids in 2 minutes. The weapons are doing exactly what they were made to do. And we have to address that. The idea of being anti-bullet hole in our patients is the public health approach, but it's insane to think that we shouldn't be talking about the fact that some of these weapons are doing the damage that I'm taking care of.
And may you both succeed. Doctor, it's good to see you. Thank you so much, Doctor. Appreciate your time
Thank you.
as well. Thanks.